for your kind introduction. So, without wasting time, I will start my talk. Uh, Today, I'm very happy to see all of you, but I'm very happy and not me. Whole country feels proud about Dr. Ajay Khanna. He is such a good multi-organ transplant surgeon, and he is currently working in Pittsburgh Medical Center. He is one of the best medical center in organ transplantation in US. So my talk is today is very simple topic, that is hypertension. From my point of view, every MBBS, every specialist, every super specialist, even those who are practicing with clinic must know about the hypertension basic cause, because every fourth person almost is suffering from this disease. All over the world, the prevalence is 20 to 25%. See, hypertension works like a domino. If blood pressure is 90% patient, they don't present any symptoms. When they are examined, they will find out hypertension. What happens with hypertension if someone is having uncontrolled blood pressure for over a period of 10 to 15 years, then it is going to harm all important organs of the body like heart, kidney, brain, eyes. Every part is affected, and that is a sort of irreversible damage. So the most important thing is how to measure accurate blood pressure. That is very important. We all are in hurry. Patient must sit at least 5 minutes in your chamber, and its position has to be all right. Cuff size is also very important. Whatever your circumference, 80% at least is your cuff size of the BP instrument. That is very important. And you must take 2 to 3 readings of blood pressure on different occasions and take average blood pressure. Then declare anybody that you are a hypertensive and you start the medication, and don't jump to the medication until unless BP is very high. Just suggest him lifestyle changes, salt, dietary advice, all these things. You must give time. And then once you proper assessing the patient, then you start your treatment. So that is one entity is like Holter is indicate ambulatory blood pressure. Sometimes it's very difficult. Everybody knows white coat hypertension, masked hypertension, nocturnal hypertension. Those are 9 dippers, resistant hypertension, episodic hypertension in certain diseases. To diagnose this, ABPM plays very important role, and it's a very simple device. Just you take a BP instrument and just walk and do your routine works, and it gives the monitoring of the 24 hours of the blood pressure recording. As per JNC 8 classification, normal blood pressure less than 120, less than 80, pre-hypertensive 120 to 139, 80 to 89, stage 1, 140, 159, 90, 99, more than 160, and 100 diastolic is the stage 2. So I'm not going to this detail. I'm just telling the summary of this. Suppose you, as a physician, you detect anybody is hypertension first time, his BP is 160 by 100. That is stage 2, 3 reading you have taken, and average BP is high. Then definitely diabetes is a very common disease like hypertension. You must rule out at least basic, and you will do the basic work, at least simple urine test, ultrasound, blood test, very important simple test, and you plan to start the medications always. So if somebody is having 160 by 100 more than BP average blood pressure after 2-3 readings, then there is a concept of starting 2 drugs together. You can start. Otherwise, single drug to be started and maximum dose to be given. Second thing, majority of them diabetic and they are associated with hypertension. Definitely ASARB is the drug of choice. Like we are dealing a lot of African population where the calcium channel blocker is drug of choice. So see our drugs which we prefer as a ASARB, calcium channel blocker, and diuretics, thiazide diuretics. If somebody is having renal failure, creatinine is GFR, creatinine is more than 2-3, then definitely we prefer furosemide or diuretics. There are some compelling indication for the medicines, like if somebody is having heart problem, like Dr. Bipul Rai sir has said, then ASARB, beta blockers of the drug of choice. Post MI, beta blocker, ACE-ARB, CAD, again the same. Then diabetes, ACE-ARB, CKD, ACE-ARB in early stage of the chronic kidney disease. It is a drug of choice. And only contraindication is hyperkalemia. If patient is not getting hyperkalemia, you must continue your drug in the chronic kidney disease. Don't jump with the 2 creatinine, 3 creatinine. No, stop this drug. This is a very good drug. It's not only protect the kidney, it protects the very vital organs of the body because of its pleiotropic and other effects. So it's a very good drugs until unless it's not contraindicated, one should not stop. This drug has to be continued. Second message about the ASARB I want to give, even if somebody is diabetic, even having normal blood pressure, and if he's having microalbuminuria positive after doing 2-3 screening, you must give ASARB to protect the kidney damage and further progression of the disease. Then there is one entirety resistant hypertension. When we are using these 3 drugs like ASARB, calcium channel blockers, and dietide, and still you are not able to control the blood pressure, then this is called the resistant hypertension. Yeah, your patient is on 4 drugs, then you can call him as a controlled resistant hypertension. But before labeling any patient to resistant hypertension, because you have to work out, to do the workup for the resistant, you must rule out the pseudo-resistant hypertension. That is very common, white coat hypertension. And second is the drug defaulter. Patient doesn't take the medicine properly. So you find his VP is too much. So don't jump very fast labeling any patient that you are having a resistant hypertension. Then out of 100, more than 90% patient, they are having essential hypertension. There is no cause. Only genetic predisposing factor, lifestyle, obesity, all these are. But secondary causes, in 10% you will get. The common secondary causes are kidney, chronic kidney disease, renal artery stenosis, they curable. Timely you do the intervention. Endocrine causes, primary aldosteronism, pheochromocytoma, Cushing, thyrotoxicosis. Then vascular coarctation of aorta, neurogenic, some psychogenic, intracranial. Really, obstructive sleep apnea syndrome, especially in developing society, obesity, this is really challenging. It's a very common cause for the resistant hypertension nowadays. And it's a, if you diagnose and treat it, it's a curable. So for the secondary hypertension, demographies like you must know older age, obesity, some black population, accessory dietary sodium intake. Then more common causes primary hyperaldosteronism, atherosclerosis, renovascular disease, sleep apnea, chronic kidney disease. Certain medication they can cause the resistant hypertension or secondary. So how to approach a patient with suspected resistant hypertension? ABPM, first 24 ambulatory blood pressure monitoring. Home blood pressure measuring is also very good method. Ask the patient to take early morning blood pressure and before going to sleep, take the blood pressure readings. Must take the reading 3-4 readings. Then you assess the patient. Then rule out the causes like take the history that he is snoring or not during the sleep. So common causes like obstructive sleep apnea, chronic kidney disease, these are the primary hyperaldosteronism, renal, these are the common. You must rule out these causes. Then attempt aggressive lifestyle and diet modification. That is very important. And then drug compliance is very important. These are the techniques, and counseling is important. So these are the techniques where how you approach a patient of resistant hypertension. Then there is a guidelines for the chronic kidney disease. Being a nephrologist, so guidelines, KDIGO, kidney disease improving global outcome guidelines for the hypertension in CKD. Usually in adult kidney transplant, we keep the BP less than 130/80. Definitely drug of choice, calcium channel or ARB we use. Otherwise, in adult patients, CKD without diabetes, I must keep the systolic blood pressure less than 120 to prevent the progression of the disease. Then obstructive sleep apnea, as I've told, it's a really common. So it's a high risk for the target organ damage. and cardiovascular complications. Majority of the patient age 50 years, BMI more than 32, neck circumference 41 centimeter female and 43 centimeter in male. Simple test is sleep study, polysomnography, apnea, hypopnea index. If it is more than 15 events per hours of the sleep, then that is suggestive of the obstructive sleep apnea. Signs, symptoms, snoring, excessive daytime sleepiness, obesity. Treatment is CPAP, weight reduction, and bariatric surgery in a selected patient plays very important role in controlling the blood pressure and preventing the further organ damage. So impact of treatment in after treating with OSA, there is improvement in hypertension 41%, diabetes mellitus 31%, COPD 54%, heart disease 56%, depression and mental health 50% improvement, insomnia 7 times increase in good quality of sleep. So this is one of the important cause for the resistant hypertension. Second important cause is the primary hyperaldosteronism. If somebody is having hypertension, young patient, having hypokalemia, metabolic alkalosis, dehydrated, then it goes more in favor of the, one must have suspicion of the primary hyperaldosteronism. Simple test is the plasma estrogen to renin level. If the patient is taking these drugs, spironolactone, eplerenone, amiloride, tremetrine, then you must hold 4 weeks prior, then do this test. If plasma aldosterone concentration more than 20, then it's a diagnostic, or if the ratio is plasma aldosterone and plasma renin more than 20. There are certain other tests like sodium loading test and the saline infusion test where you measure the plasma aldosterone level. If it is more than 10, then definitely is in favor of primary aldosteronism. One must do. The imagine CT scan, MRI, and adrenal venous sampling when you are taking the decision for the surgery. It is otherwise majority of the time CT scan and MRI will tell, and your blood test will tell the diagnosis, and you will to make it manage the treatment. So this is just flow the chart for the adrenal. If you do the CT scan, if there is unilateral hypodense lesion, of course, if he is young, then laparoscopic adrenalectomy is the treatment of choice. But if suppose older than 40 years, and if suppose patient is having micronodular bilateral masses, then of course in this adrenal vein sampling is important. Then you do the adrenal gland removal of the gland. Otherwise, majority of the patient they control with the pharmacological therapy by using the spironolactone, epinephrine drugs. Then this is a very rare cause, but it's a pheochromocytoma. So just few slides, patient will have a incidence is very less, 0.1% of hypertension population. And male, female, it is equal. Usually in 3rd and 5th decade of life, patient will get rare symptoms. You will get paroxysm of symptoms of in pheochromocytoma. Patient will have tachycardia, angina, perspiration, all these symptoms, and episodic hypertension. Then it is more, you must have suspicion for the pheochromocytoma. Abdominal pain, chest pain, CHF, all these can happen. Then there is a rule of 10 in pheos. 10% extra-adrenal, 10% occurs in children, 10% familiar, 10% bilateral, 10% recur more extra-adrenal, 10% malignant, and 10% discovered incidentally. So simple test by doing the urinary test by catecholamines, metanephrines level, then plasma catecholamines level fast test. Then the important thing you can diagnose by doing the CT and doing the MRI, and the specific test that is good is MIBG scan that will tell you extra adrenal location, and are equal sensitivity and specificity. The PET DOTA also tells you the location, which type of you are dealing with the pheos. Treatment is alpha beta blocker. You first keep the patient in alpha beta blocker, then do the surgery and localize the tumor and do the surgery. The last important topic is renal artery stenosis, which is very common cause, and majority of the time it's a curable. So since time is over, I'm going to make it very short. Two most important causes. One is the atherosclerosis and one is the fibromuscular dysplasia. muscular dysplasia is a young age disease. It's a female disease. Some is requiring more than 4 drugs, 5 drugs, having accelerated hypertension and fundus changes such, then one must suspect for the fibromuscular dysplasia. Otherwise, it's an elderly disease, atherosclerosis, 3/4 of the patient, renal artery stenosis, they are atherosclerotic. This is a fibromuscular dysplasia. Usually distal part of the renal artery is involved, and very good response with PTCA. Dr. Vipul Rai will tell you better, but it's a treatment of choice where the patient response is very good, and majority of the time it's 82 to 100% success rate, restenosis 10%, and cure of hypertension in more than 60% of the patient. It is atherosclerotic renal disease. Incidence is very high, and it's a progressive disease because it's a diffuse systemic disease. So for intervention, you have to think twice before doing intervention. Still, medical therapy is the treatment of choice in majority of the patient. So you will get all these symptoms: accelerated hypertension, unilateral kidney, and all these things. How to diagnose? The standard is as Dr. Vipul Rai told, gold standard is always arteriogram, but non-invasive test, MRI, CT, angio, if renal function is normal, duplex ultrasound, even if the renal failure, gives a quite good idea about the renal artery stenosis. And if your clinical suspicion is high, you can make the diagnosis easily. This is a Doppler. If the peak systolic velocity more than 100, more than 80, more in favor of the renal artery, it's a non-invasive test. Then you can go further for CT, MRI. So usually, if the stenosis is more than 90%, one must do always intervention, because if you don't do, the kidney is going to have a ischemic renal disease and kidney is going to damage. But if stenosis is less than 80%, medical treatment is still a drug of choice. If single kidney is involved, ACE-ARB is the drug of choice. You can maintain the patient on medical treatment. He needs follow-up. The last thing about to whom you will do the intervention in atherosclerotic renal artery disease. If suppose you have used ACE-ARB and patient is having deteriorating renal function, or your one kidney is small, or patient is having solitary kidney and deteriorating renal function, then you must do. Or if the patient is having accelerated malignant hypertension and flash pulmonary edema, recurrent pulmonary edema, that is the indication to do the intervention in a atherosclerotic renal artery disease. Second, atherosclerotic renal disease, majority of its proximal part is involved. So stenting plays a very important role in atherosclerotic disease to prevent from the malignant or accelerated. Surgical revascularization usually will do, mortality is very high, but aortic reconstruction, multiple small renal arteries, these are the indication for the surgical revascularization. So in the last, to summarize, how measurement of blood pressure is very important. Don't be in a hurry to making the diagnosis. Give patient at least 2-3 reading. Take proper BP. Ask him to do the lifestyle changes. And even if it is hypertensive, then you start with the one drug. If it is he presented with first time with very high BP, 160, 100, more than PEP, all these features, then you must use the double drugs, maximum dosage. Then secondary hypertension should have a strong suspicion if somebody is having resistant hypertension, and it has to be diagnosed. These are the common diseases which I have discussed. And if you treat them, most of the patient, they will become all right. Then drug adherence is very important. Side effect monitoring, regular follow-up. This is very important because it's a lifetime disease. Then definitely there is a need to increase awareness regarding hypertension in society, as a majority of the patients are asymptomatic, I have told. My last slide, this month, 13th August was the organ donation day. And we are so many steps behind as compared to developed society for the cadaveric organ donation. So I request all of you, for everyone, for the awareness for the organ donation. A single cadaver can save the life of at least 6 persons. So, and we all are doing all transplants in our country also. So there is a need to increase the cadaver donation. With this, thank you very much.